Okay, well, welcome everybody back to this session of the Odyssey Asia Pacific Symposium. We've had a great session this morning and this one's going to be even better. So we're going to talk about a few network studies that we've been performing across the Asia Pacific network. So I'm going to hand over now to Patrick, who will introduce our first speaker. Thank you.
And we're going to hear from Martijn Schuemie.
Hello everyone, I'm Martijn Schuemie, and I'm excited and honored to be here to present to you on the LEGEND principles. So LEGEND stands for Large-Scale Evidence Generation and Evaluation across a network of databases. But what is LEGEND? Well, LEGEND is a group of Odyssey collaborators who have set a goal for themselves to generate evidence at large scale. They have defined 10 guiding principles, and they've actually already applied those principles to publish several articles, including one in JAMA, one in Lancet, and 2 in JAMIA. And more papers are on the way. So what are these principles? Let's go through them one at a time. So the first one is that evidence will be generated at large scale, as the first letter of LEGEND implies. But what do we mean by large scale? So what I'm showing you on the right is a complicated diagram that tries to explain all the analysis that we did in our LEGEND hypertension study, our most recent LEGEND study. Let me summarize that what we did is we compared all hypertension treatments that we could find, both monotherapy, but also combination therapies. For each comparison between treatments, we looked at 55 outcomes of interest, and these included both safety outcomes and effectiveness outcomes. And in total, this led to a formulation of almost 700,000 research questions, where every research question basically made a comparison between a target treatment, a comparator treatment for an outcome of interest. So trying to estimate an effect size, a hazard ratio for that combination. Now, one reason why we wanted LEGEND to be producing evidence at large scale is, as you probably expect, to be complete, to provide a complete evidence base to medical decision makers. What I'm showing you here in this diagram is a plot representing the randomized trials that have been done for hypertension treatments, where every one of those circles, every one of those dots is a hypertension treatment, in this case focusing just on monotherapy, and every line represents one or more randomized trials that was done to compare two treatments. Now, hypertension is an area where there's been a lot of research, a lot of randomized trials, so there are quite a few lines in this plot. But I think you'll agree with me that that pales in comparison to the comparisons that were made in LEGEND. And this is just for the monotherapies. So LEGEND can answer many more questions than we could ever answer with randomized trials. But there's a second reason why we want to generate evidence at large scale. And that brings me to the next 3 principles of LEGEND. The second principle states that dissemination of evidence will not depend on the estimated effects, meaning that no matter whether we observe the effect to be large or small, significant or not, we will communicate the effect to whoever wants to hear about it. Furthermore, principle 3 states that evidence will be generated using a pre-specified analysis design. So we will design the study, execute it, and then afterwards we're not allowed to modify that design anymore. Lastly, evidence will be generated by consistently applying a systematic approach across all research questions. So there's no fine-tuning of any analysis for one specific exposure or one specific outcome. Now, the reasons why we have those principles is because we want to avoid publication bias and p-hacking. And you probably have heard those terms, but let me just try and explain what that looks like in reality. So you might actually recognize that this, if it happens in your surrounding. So this is how a study typically goes. You have an idea for a research question, you go to your data, you perform your analysis, And then you submit your paper to a journal. But what you probably have found, like so many others, is that if you didn't observe a statistically significant effect in your study, it's actually very hard to get that published. Journals like to show interesting things, and showing that there is an effect apparently is more interesting than not showing that there is an effect. So if you're not statistically significant, then maybe you won't get published. Next time around, you again have an idea, you do your study, but not statistically significant, so no publication. Maybe the next time, once you've done your analysis and you find that haven't achieved statistical significance, you won't even bother to submit it anymore until maybe one day you've reached statistical significance, you submit it, and the journal likes it and publishes it. Now, this is actually a very problematic way of working. And the reason for that is that a p-value or confidence interval is supposed to give you some probability, the chance of observing something if there's no effect. And if you do many studies, even if there in reality is no effect, then 1 in 20, 5% of them, you would expect to have statistical significance, even if there is no real effect. Similarly, p-hacking works in almost the same way, where we have a idea for a research question and we do our analysis. And if it's not significant, then we might actually go back to our analysis, thinking I must have forgotten something, like a missing covariate that needs to be included, or we need to redefine our exposure cohorts, or our outcome definition is no good, until we get to a point where, oh, now it's statistically significant, and we publish it. And this is actually problematic for exactly the same reason why publication bias is problematic. So publication bias and p-hacking are problematic because they lead to a very high false positive rate. And John Ioannidis a few years back wrote this paper where, based primarily on these problems, he concluded that most published research findings are false, which I would argue is a major problem for us. Another problem that stems from this is that we have a lack of evidence on null and small effects. So if an effect is small, or actually there is no effect, then it's very hard to get a paper published that actually shows that that is the case. And so as a medical decision maker, you will not have that evidence at your fingertips. So that's why in Legend, all the analyses are pre-specified and all of our results are disseminated without filter on whether or not they show an effect. The fifth Legend principle states that evidence will be generated using best practices. So no cutting corners just because we are working at a very large scale. We always need to use the best methodology available at the time. So one best practice that I would briefly like to go into is the advanced confounding adjustment that we use in our Odyssey studies. What we do here is we construct a large generic set of covariates. And by generic, I mean that the covariates are actually the same no matter what the exposures or the outcomes are. It's just always all drugs, all outcomes, all procedures, etc. We then fit a regularized regression model for the propensity model. We match or stratify on the propensity score. And what we've observed time and again, which I find actually very fascinating, is that what we achieve is balance on all the covariates. We typically achieve balance on all covariates. So even if we have almost 60,000 covariates, on every one of them, we achieve balance, measured as standardized difference of means smaller than 0.1 on each of those covariates without exception. So that gives us an indication that we have managed to balance these populations properly and can continue to do our study. And this procedure has been described in this paper led by Yuxi Chang. The sixth principle states that the evidence generation process will be empirically evaluated by including control research questions where the true effect size is known. Now, a study can be viewed as a measuring instrument. Just like a scale is used to measure a weight of an object, a study is an instrument to measure an effect. and to measure the effect size. And just like a scale, if you want to know whether your scale is accurate, what you would do is you put weights on the scale where you know the mass of those weights, and you see whether the scale reports the correct weight. And similarly for observational studies, what we do is we include control questions. So these are questions, exposure outcome pairs, where we know the effect size. And so we typically have two types. We have negative and positive controls, where negative controls are questions where we know that the answer is there is no effect. And positive controls, we know that there is some effect of a certain magnitude. And then we can test whether or not our study design actually produces those results. And just like if you find that your scale is off by a little bit, you can actually calibrate your scale so that it becomes well calibrated again. So we can do that with observational studies. And so we've developed this technique called empirical calibration to adjust our analysis based on what we observe for our negative and positive controls. And so this has been described in several papers, including the one I'm showing on the screen now. The seventh principle states that evidence will be generated using open source software that is freely available to all. And this is also the case with our LEGEND hypertension study. The study package and R package is available on the GitHub repository. You can download it and run it. But I think even more importantly, that the LEGEND study, just like most Odyssey studies, uses our large set of tools that have already been developed. And so in this case, the HADES, or Health Analytics Data to Evidence Suite, played a very important role in our LEGEND studies. And HADES is a set of R packages that you can use to quickly put together a very complicated study, implementing the best practices that I mentioned before. LEGEND will not be used to evaluate methods. So this principle is mainly aimed at people like me who would like to develop and evaluate new methods. And every time I need to catch myself in that LEGEND is aimed at generating evidence, clinical evidence, not at evaluating methods. So even though we have this cool idea for a fancy new method, we should evaluate that in a separate study, and only once we believe that it's good enough can we apply it in LEGEND. This is a corollary of our principle that says that we always need to use best practices, because if a method still needs to be evaluated, then by definition it cannot be best practice. LEGEND will generate evidence across a network of multiple databases. I think that's important for several reasons. So I'm just showing you here a plot from our Lancet paper where we, for several effects, we show the results across databases. So it's important that we replicate our studies across multiple databases. One reason that probably is first in mind is that we would have more data, more statistical power. So if we perform the same study across a network of databases like we do in LEGEND, we do have more people, more data, and therefore we tend to get more accurate estimates with narrower confidence intervals. But for me, actually, the most important reason to run a LEGEND study across multiple databases is to see whether we actually find the same effect in all of the databases. If we were to observe something in one database but not in 8 others, then that would actually make me doubt the result. Whereas if we do replicate it everywhere, at least then we've passed that point of falsification. Finally, the last LEGEND principle states that no patient-level data will be shared between sites in the network, only aggregate data. And this is, I think, is true for Odyssey studies in general. And so in LEGEND, like in all Odyssey studies, we have multiple sites with data, some, for example, hospital electronic health records, some administrative claims. All of this data has been converted into the common data model, but may not be shared at the patient level as patient level data. It all sits behind everyone's own firewall. In a study, Odyssey study, like a LEGEND study, what happens is that any site can be the lead of the study, and that site then develops the analysis code, so usually a R package, a study package, and that package is then distributed to every one of the sites. And so we bring the code to the data, not the data to the code. The sites then run that code locally behind the firewall, generating aggregate statistics, and those are then shared back to the central site, the study lead, to be synthesized into a answer. So this is the procedure we also use in legend studies. So those are the legend principles, and to get an idea of how well this works, we've done this comparison because we believe that the reason why we have these principles is we want to generate reliable evidence, and to see whether we've actually succeeded in that, one of the things we did is we compared the results coming out of legend to meta-analysis of randomized trials. And meta-analysis of randomized trials is considered the highest level of evidence that we can have in the medical domain. And so we want to see how far off legend is from that type of evidence. And so what I'm showing you here in this plot, this is in one of our JMIA papers, is the black estimates, the black dots and lines are the estimates and confidence intervals coming from the meta-analysis of the randomized trials. So that's our gold standard, if you will. The green estimates and red estimates are the ones coming from the legend. That's the meta-analysis across the legend databases, empirically calibrated. Red means that there's significant disagreement between the RCT meta-analysis and the legend meta-analysis. Green means that there's no significant difference. Now what we see in this is that the estimates were not statistically significantly different more often than expected by chance, because we're doing a lot of comparisons here. You would expect 5% of those comparisons to be in disagreement, even or be statistically significantly different, even though there is no real difference. In this case, it's 2 out of the set, which is I think about 6%. So that's actually in line with expectation. What we also see is that the legend estimates have much narrower confidence intervals. This is maybe not surprising. Even the largest randomized trial has at most 10,000 people or something, whereas in our observational databases, some of these drugs, we have millions of people exposed. And so even though there is not a significant difference between the RCT estimate and the legend estimate, it can very well be that the confidence interval from the RCT is so wide that it includes one, so not able to reject the null hypothesis, whereas a legend estimate has a much narrower confidence interval, completely within the confidence interval of the randomized trials, but showing an effect just because it's so much narrower. So even though we're in agreement with the RCTs, you could argue that there actually is a lot learned by the legend study in that we have a much clearer idea of the effect size. Now, we do need to make one note just to dampen everybody's enthusiasm. The RCTs, even though these are large trials and many trials, they actually have pretty wide confidence intervals. And so you could actually do pretty much as well as legend if you just always guessed that there is no effect. So yes, these results are promising, but it's also not entirely convincing just because our gold standard actually still has quite a bit of uncertainty in it. So in conclusion, I would argue that the legend principles aim to improve transparency, so be very clear about what we've done and why, and also to ensure verification, so to make sure that the evidence that we produce is of high quality. And so we hope that more studies will start to follow these principles. And with that, I would like to thank you for your attention.
Great, well, thank you very much, Martijn, for that really important overview of the legend principles. Now we're actually going to hear from Yuan about how we're actually going to use these principles to design and implement a network study across the Asia-Pacific region to investigate the comparative effectiveness and safety of second-line antihypertension treatments. So I'll pass over now to Wong. Thank you. Great, well, thank you very much, Martijn, for that really important overview of the legend principles. Now we're actually going to hear from Yuan about how we're actually going to use these principles to.
I'm Yuan Lu, Assistant Professor at Yale School of Medicine. I'm honored to be here today to present to you our first Odyssey APAC collaborating work, Comprehensive Comparative Effectiveness and Safety of Second-Line Antihypertensive Agent. Hopefully from Martijn's presentation, you now have an idea of what legend principles are. Now I'm going to talk about how we apply to mobilize collaboration across Odyssey APAC Network. I must say that this study is really a teamwork. We have 25 collaborators from 16 institutions. Without their contribution, this collaborating work cannot be done. For today's talk, I will first describe our rationale of this study. Why do we think it's important to do this study? Then I will talk about the study objective, methods, as well as committed data source. Finally, I will show you some preliminary finding of our analysis. As we all know, hypertension is a major modifiable risk factor for cardiovascular disease. It contributes to 1/3 of the ischemic heart disease and half of the stroke in the world. Hypertension is really a global issue. This figure shows the age standardized prevalence of hypertension in adults in 2015. Despite some variation across regions, hypertension is highly prevalent in every single region of the world, for both men and women. In 2015, a total of 1.13 billion of people, that is 1/3 of the global adult population, had hypertension. Hypertension is particularly relevant to Asia. 50% of the global hypertension population live in Asia. Asia region, as colored in orange and brown in the figure on the right, has the largest population of hypertension compared to other regions. Hosting 60% of the world's current population, Asia has observed a high growth rate in hypertension from 1975 to 2015. The increase is mostly due to change in population size and age structure. As the population continues to age, hypertension will be a major public health threat in Asian countries. A global epidemic requires a global response. Odyssey is a multi-stakeholder, interdisciplinary collaborative to bring out the value of health data through large-scale analytics. It is in an ideal position to provide high-quality evidence in response to hypertension epidemic. The Legend Hypertension is a landmark study that leverages Odyssey community to access a global network of database and apply state-of-the-art informatic approaches to comprehensively compare first-line antihypertensive medications. This successful collaborative work, published in The Lancet, really set up a model for other Odyssey network studies to follow. However, there are still questions that has not been addressed in this study. Specifically, for many patients, blood pressure control goal cannot be achieved by monotherapy. Uncertainty remains about the optimal second drugs added to monotherapy. There is a lack of high-quality evidence from randomized controlled trial. Only one major trial, Accomplished, has compared a limited set of combination therapy. And it has not looked at subgroup analysis by key patient subgroups. As such, the current guidelines are unable to provide recommendations regarding preferred drugs for treatment escalation. Accordingly, we propose the Odyssey APAC study to address the gap in evidence. As an extension of the Legend Hypertension Initiative, we aim to develop, implement, and execute a systematic observational study that provides a comprehensive comparison of dual combinations of 4 major antihypertensive agent classes for treatment escalation. We will carry out 3 specific aims. Aim 1 is to describe real-world utilization of dual combination therapy for treatment escalation among people with hypertension, overall and across subgroups by age, sex, history of cardiovascular disease, and country. Aim 2 is to determine real-world effectiveness of dual combination therapy on 9 effectiveness outcomes. And Aim 3 is to determine the real-world risk of adverse events and benefit on 46 safety outcomes. Specifically, we will employ an active comparators new user cohort design. We will model the study on Legend hypertensive Lancet paper. We will apply Legend guiding principles as shown on the right figure here. This is a really dense figure, but I want to highlight that we will follow the Legend guiding principles from the start of the study in defining study questions to the end of the study in dissemination of study findings. Our cohort definition is depicted in this slide. We included data from 2000 to 2019. The cohort entry event is the start of a new drug for treatment escalation. We consider the initiation of the second drug as the index date. And there are several inclusion criteria based on the index date. For example, we require at least 1 year of prior continuous observation period to see the index date. We also require a diagnosis of hypertension at any time prior to the index date, a history of antihypertensive monotherapy at any time prior to the index date. We require at least 30 days between the initiation of the first drug class and the initiation of the second drug class. This will make sure the combination therapy is started as a two-step treatment instead of using it as initial therapy. We also require no diagnosis of primary outcome prior to the index date. In our first aims for treatment utilization, I want to mention that we relaxed this inclusion criteria of no diagnosis primary outcome. This will allow us to compare patients with and without history of cardiovascular disease. And then we also require patients have exposure to the combination therapy for at least 180 days. So that's as shown on the figure here, no other drug classes initiated within 180 days after the index date. The cohort exit events are either end of the observation or treatment discontinuation. Here we consider 4 major drug classes: ACE inhibitor or ARBs, angiotensin receptor blocker, calcium channel blocker, beta blocker, 5-FI or 5-FI-like diuretics. Based on these 4 different drug classes, we construct 12 exposure cohorts. These represent all different combinations of these 4 drug classes. The definition of each cohort is publicly available on ALICE. We will perform A-class comparisons. For each comparison, we are holding the first drug the same and examining different second drugs added to treatment escalation. In terms of outcome, we will examine 9 effectiveness outcomes. These include 3 primary outcomes based on the 2017 AHA-ACC guideline systematic review. These are acute myocardial infarction, hospitalization for heart failure, and stroke, and also 6 secondary effectiveness outcomes that major hypertensive treatment RCT has considered. We also included 46 safety outcomes. All the phenotype definition of these outcomes are available online. They have been previously defined in the Legend hypertension study and can be accessed through the link here. As for now, we have 9 committed data sources, included 8 EHR databases and 1 administrative claim database. Together, these committed data sources cover 21 million patients in 5 countries in Asia Pacific region. Let me show you some preliminary results. We have 6 data sources that already run the feasibility analysis, and these are the distribution across cohort. We can see significant variation across database, and cohort 1 and cohort 2 are by far the most commonly used drug classes in treatment escalation. Next, we look at cohort characterization by key patient subgroups. First, look at characterization by gender. The gender ratio of hypertensive patients are almost 1-to-1. Women are more likely to be in cohort number 4, diuretic plus ACE inhibitor or ARB. Cohort number 8, diuretic plus calcium channel blocker. Cohort number 12, beta blocker plus diuretic compared to men. This is surprisingly consistent across all the database. Now let's look at characterization by age. The majority of cohort number 1, ACE inhibitor or ARBs plus calcium channel blocker. Cohort number 3, ACE inhibitors or ARBs plus diuretics, are in age 45 to 64 years old. Whereas the majority of cohort number 7, calcium channel blocker plus diuretic, cohort number 9, calcium channel blocker plus beta blocker, and cohort number 10, beta blocker plus diuretics, are in age 65 and above. The drug utilization in Australia and Singapore is higher in age 65 and above, whereas in Korea, the drug utilization is higher in age 45 to 64. Next, let's look at characterization by history of CVD. As we expected, most patients do not have history of CVD. Among those with history of CVD, cohort number 5 and cohort number 6, which are ACE inhibitor or ARBs plus beta blocker, or vice versa, are highly prevalent. These findings make sense. It is consistent with the guideline for secondary prevention of cardiovascular disease. The current guideline recommends using these therapies to reduce risk among patients with CVD. Finally, we look at treatment pathways in 3 different countries. This is Australia LBT database, Korean database, and Singapore database. By just looking at these sunburns plots, our first impression is that there are significant variation in drug utilization across countries. Taking a closer look, we found that the most common first-line therapy of patients in Australia and Singapore is ACE inhibitors or ARBs, whereas the most commonly used first-line therapy in Korean patients is calcium channel blocker. Interestingly, there are more patients in Australia who have second-line treatment than Korean patients. This work is still ongoing. At the end of the study, we expect that we will provide high-quality real-world evidence to inform treatment decisions for millions of patients with hypertension, healthcare providers, and policymakers. I'm excited about it. I hope you feel so too. If you want to join the Odyssey APAC study group, please feel free to contact us. This is our contact information. With that, thank you for your attention.
All right, thank you for the wonderful presentations from both Martijn and Professor Yuan Lu on the hypertension and LEGEND study. We do have, we're going to move forward into the Q&A session. We have quite a few questions that are out there, so we're going to ask, we have a little time, and we're going to ask the panelists that we have on this call to help us with some of these questions. The first one that I would like to ask, which Professor Lu did mention a little bit at the end, is how does the workflow, what is the workflow for joining this Odyssey APAC study, as well as is it possible to download the cohort definition to run it within their system? Jing, is that something you want to take on?
Can you hear me?
Yep.
Awesome. Yeah, so I think for the workflow, so we do have a Google link that is out there, and also you could visit the odyssey.org for the workflow. So I think if you're in Asian Pacific, so definitely I think either you can contact your region leader. So if you're in mainland China, feel free to contact me. Our information you can find under, within the APAC Symposium, because when you click on somewhere, you can see their email. So if you're in mainland China, please contact me. That's fine. And then if you're kind of in Hong Kong or Singapore, we do have different region leaders that which you will meet tomorrow in our regional chapter. That I think that will be a place you can ask your regional leader about, how to participate or how is your region's involvement in this study so far. So I think please join the tomorrow's chapter breakout. I think that will be a very good start point to get to know who else is in your region and how's your region's involvement and how do we start from there. So I think tomorrow will be a good time to join.
Awesome. Thank you, Jing. The next question that we have that is not actually published yet is can the panelists here discuss how much the legend principles improve your confidence in the reliability of evidence generated and why? Nicole, is that something you want to comment on? Sorry, Nicole, you're on mute.
You're on mute.
Okay, sorry about that. I was saying that that's a very complex question to answer, but for me personally, I think the legend principles really talk to the transparency of observational studies and really articulating exactly what it is that the observational study is doing, how it's doing it, and what are the safeguards that we're using against things like confounding or bias, and really understanding the technical details of the study we're doing. So I think for me, what I've got from the legend principle is that transparency is such an important factor in producing reliable and interpretable evidence for clinical practice.
Awesome. Chan, do you want to comment on this one as well?
Okay, so as you know, the 10 principles of legend is again, it was pre-specified before conducting the study, and it is really important that we specify all the protocols before performing the study to avoid the p-hacking or the hypothesizing after the results are known. And then to avoid the publication bias, we disseminate our evidence to the public. So it is really promote the open science and transparency in the science. That is really that should be acknowledged too. Again, it uses very diverse databases. So there is no perfect database in the world. I do believe in that. We do not have the perfect database. So every database has their own meanings and their own population, their own medical service practices. So it is really important to use various databases representing various population and various medical practices in that system, and they are collecting systems. So that's the power of Odyssey, and that's the power of the legend, I think. Thanks.
Okay, Chan, I know you've been answering in some of the questions, but I was wondering if you can elaborate a little bit more on the question that's talking about the legend and whether or not, there are a lot of people, more and more people diagnosed with hypertension nowadays. Is there any plans for expanding the current legend findings? I know you submitted some posts already, but can you elaborate on really what are some of the work that the legend group is doing to help expand this?
So Professor Krumholz of the Yale University recently published a paper about the legend of hypertension, and he said that if we treat the hypertension like we treat or investigate the COVID-19, then we can save millions of people. Even though it is not yet published, published yet, but I found that beta blocker is worse choice for treating hypertension than other recommended classes, because there is no definite evidence for beta blocker, and many clinicians are still using beta blockers for treating their hypertensive patients. So if we reduce those wrong medications on these large amount of people, then we can save millions of people again. And Sushard actually estimate the number of the patients we can save in his last paper, that if we uses the best medication, which is thiazide, because thiazide is the cheapest and the most effective medication, which is not really widely used. As Yuan showed that especially in Asia, we do not use thiazide much. That is a little bit shameful, and there is we can change our practice to better way. There is a really big space to improve our practice for hypertension.
Thank you, Chan. The hypertension study that you guys just heard about is actually initiated by one of the professors at Yale University. And I heard 2 weeks ago or so, there was another announcement with the original team who did the legend study with Harlan. So Patrick, I was wondering if you can elaborate a little bit on the work that happened over there, and what is it that Harlan is now doing?
Yeah, thanks, Mui. So one of the things that we really are aspiring to do with these legend principles is to create a community of researchers who are interested in applying these principles to really target disease areas and try to produce a holistic collection of evidence that helps us understand the disease. In the case of our legend hypertension study, the initial analysis and result set, as Martijn presented, looks at individual ingredients and compares them head to head. It looks at classes of drugs and compares them. It looks at initial treatment of combination therapy and compares the impact of monotherapy versus combination therapy. The result set's pretty extensive, but the insights that could be gained as it relates to answering the very targeted clinical questions, each of those clinical questions requires a thorough examination. And as Dr. Lu presented, there are even additional questions beyond the millions of analysis estimates that were produced in the original legend study. As Chan highlighted, an investigation in the effects of beta blockers is an example of one of those targeted clinical questions that we've investigated. George mentioned that we look specifically at a head-to-head comparison of chlorothalidone versus hydrochlorothiazide. The original paper that was published in Lancet specifically looked at class effects. We actually anticipate that there's going to be a large collection of studies that will come out of the one legend result set. And the principle that I guess I'd really want people to think about is that it is very common that a researcher has one question and one hypothesis. They choose one method, they apply it to one database, they get their one answer, and then they may or may not publish it. And that process is very much what Martijn highlighted in his presentation, that can result in publication bias and p-hacking and whatnot. We're trying to flip that process on its head by instead saying, what if we objectively produce all the evidence for the disease area and then have a coordinated effort to explore the evidence and interpret what we find and try to contextualize the information to answer these hypotheses. And so I think what the original hypertension work represents, as well as the new proposed study in the Asia Pacific region, represents this idea of creating an entire disease-based agenda that we can dive into that can continue to spawn specific clinical insights that can hopefully improve clinical care. We are expecting that this model that we've applied now to depression and now we've applied it to hypertension is a model that we can and should be applying to other disease states. As Danny Prieto briefly alluded to, we're trying to apply the legend principles to the comparative effectiveness studies within COVID-19. And we're also looking to apply the legend principles in the area of type 2 diabetes. But I think that the thing that I'm most excited about is the idea that as a community, we can come together to collectively establish a best practice approach to generate a large result set. And then together we can divide and conquer on gaining the clinical insights that we think are actionable and worth disseminating through publication, and also getting those answers in the hands of clinicians so that they can improve the care they deliver to patients.
Thank you, Patrick. That was extremely detailed and very interesting, and looking forward to, what the community is doing and more of the results that are going to come out from this. So the next question we have is how to better control are there better controls basically for the confounding factors in observational study? Nicole, do you want to take that one?
Yeah, sure. So control for confounding in observational studies obviously is a really important concept, and the way that Legend has approached this is kind of in three different ways. The first is really to use the large-scale propensity score methodology. So, as you know, the propensity score, looking at the probability of treatment, and then we either match on the propensity score or use propensity score strata. So we did both of those analyses, and we were able to then compare the characteristics between our matched group and have we actually adjusted for those confounding factors that were not evenly distributed prior to the propensity score matching. So that's a large sort of area, a methodology that we've used to allow for measured confounding in the Legend studies. And I see that Chan has put there a really nice reference to a study that you can read all about how we do propensity score adjustment in the Legend framework. Second is the use of calibration, I should say. So again, we saw that in Martijn's presentation about the use of positive and negative controls and how we might use those to really understand the distribution of a potential bias that might be there in the study design that we have chosen to implement. So again, I think, Chan, you've also put another, or perhaps you can look for the references to how you actually do this large scale calibration for positive and negative controls as we've referenced them in the principal study. And third, we also can look at how well our study has adjusted for confounding by comparing against the clinical trials. And again, Martijn showed us how after doing the propensity score and doing the calibration, we were able to really find results that were in line with those that we would expect from the randomised clinical trials. So really those three sort of broad areas are how we can work towards controlling for confounding factors in our observational studies in these large-scale studies. That's probably enough.
Thank you, Nicole. Chen, would you like to add on to that?
Okay, so basically, I'd like to add two more points on that. So first of all, the large-scale propensity score model, which was just more than 10,000 variables, and this large set of covariates can serve as like a proxy for the hidden confounder. So we found that even though our propensity score model did not include the blood pressure as its covariates, but the result from the legend hypertension was not sensitive to the baseline blood pressure, and actually the matched patients actually have the balanced baseline blood pressure. And the second point is that the empirical equipool is really important theme, I think, because if there is no sufficient overlap between the target and computer in terms of propensity score or preference score, then it is not the comparable sets. So in that case, we recommend to conduct a clinical trial rather than observational study. So that's what I want to say. And for the other question the question, what is the novelty of this legend hypertension? I think that it is really novel because the most available evidence for hypertension is actually drawn from the hypertensive patients with very many comorbidities. So in this study, we targeted on the treatment-naive hypertensive patients, which is hardly targeted for the randomized clinical trials. Most clinical trials actually targeted on the very hypertensive patients with a very high risk because because they need to find some significant outcome difference between the groups. So this is the novelty of this. Another novelty of this study in clinical viewpoint. That's it. Thanks.
All right. Well, thank you very much for that great Q&A session. Keep posting your questions if you have any. But right now we're going to move right along to our next presenter, Professor Ian Wong. And Professor Wong will be talking us today about his network study on the comparative effectiveness and safety of oral anticoagulants in people with atrial fibrillation. So take it away, Ian. Thank you.
Right. Can you see my screen?
Yep.
Okay, that's great. It works. Thank you very much, everybody. And so it's great to be able to speak today and to see all the wonderful old friends and also the new people. So it's great. So I'm going to talk about our comparative effectiveness and the safety of direct oral anticoagulant in patients with atrial fibrillation. A standardized observational data network study is a CORAZON study. So basically, I presented on behalf of the UCL and also the Hong Kong U and of course Odyssey. I'm going to give you the contents of the study. Is a brief introduction to our research team and then the study background, objective, method, result, and discussion. So this is the place that I work in both sides. I usually work in London and also in Hong Kong. And so we have quite an interesting team in both sides. And so we like to have visitors. So come to see us in London, pretty nice place. And similarly in Hong Kong. We actually work on the common data model and also looking into the Asian database for quite a while with some of our colleagues. Patrick is also in this paper. We look into the opportunity in the past many times before And then we work on some of the study, not precisely in Odyssey, but it's in common data model. So this is some of the work that we've done between the UCL, Hong Kong, and also with Nicole in here. And so that is the background that we use the common data model for quite a while. But having said that, this time we are looking into is anticoagulant. So our team been working on anticoagulant for a long time. In the past, we only used the data mainly from Hong Kong or from UK. So we work on a lot of different hypotheses, like what Martijn talked about earlier on, that we do the study using our hypothesis, we run the study, and but then after we've done quite a lot of single site study, we start to realize that we definitely need to have a wider database to allow us to actually looking into the use of anticoagulant in a much wider scale, and also looking into not just one single outcome, but looking into some range of the outcome they are actually important to patients. So that's why we come up with this particular idea. So this journey is actually a very interesting journey. So I have a discussion with Martijn about, we've been running a lot of single site study, and we've done a lot of anticoagulant study, but we really want to actually run a multinational study and to also looking into multiple outcome, which is significant to the patients. And then Martijn basically say, you should use Odyssey. And then my answer is say, look, I haven't been using Odyssey to run studies, so I'm not sure whether I can do that. And then beautifully, Martijn say, of course you can. And then he passed me to Mui, today's chair in here. And then we start to go through the process to talk about what exactly we want to study. And then I was guided through the whole process with my team together. And I think this is highly beautiful study, from my point of view, because people say that you can't teach an old dog a new trick. And this time the old dog is learning the new trick through the Odyssey. So I encourage all of you to look into what you can do with Odyssey. So give you the background about anticoagulant, and also with the atrial fibrillation. The atrial fibrillation is one of the most common cardiac arrhythmia. It's affecting 33 million people worldwide. It's the leading cause of stroke. It's devastating. If you have any relative or any patient, they have stroke, you know how devastating for a patient to have a stroke. And current guideline actually recommend to use the direct oral anticoagulant, what we call DOACs, over the warfarin in stroke prevention in AF patient. But we actually have very little to go on to compare between the DOACs. And almost all the clinical trials are actually so far been published on DOAC compared with warfarin. Clearly that, for a company, they market the drug they're interested is to say, hey, my new drug is actually better than the old drug. But then in real life, the clinician, they're facing the patient, is not talking about just the old drugs and the new drugs, but among the new drugs, what are the evidence? How are we going to choose which one is better? Whether we like it or not, that is a lot to do with the marketing side of it, rather than the actual evidence guide the practice. So this is what we have at the moment, or from the clinical trial, looking into the comparison between the DOAC with the warfarin. So some are actually better, some are more or less the same as the warfarin. But this is no longer the question of whether the DOAC, the direct oral anticoagulant, is better than warfarin or not. We know they're actually better already, or at least no worse than them. So the question is, how about compare between the different DOACs? So we came up with this idea that we really need to compare the effectiveness and the safety outcomes of the DOAC. Currently market, there are 4 different ones: dibegatrant, rivaroxaban, apixaban, and etazoban. And so we're looking into the outcome of interest: the ischemic stroke, systemic embolism, intracranial bleeding, gastrointestinal bleeding. So they are the major outcomes that we are really keen to look into. So for this particular one, we have the 5 database from 4 different countries, cover data from hospitals and outpatient setting. Those are the data provided by IQVIA, and we have a community call on and to ask for other people to join us. So far we have those data, database provided data from France, Germany, UK, US. I'm not going to go through all of them, but it shows you the number of the patients in here. So the method is we're looking at the exposures of different DOAC, and also we're looking into the outcome that I mentioned already. It's a new user cohort using the population leveled estimation study. So the 4 drug exposure cohorts and 3 outcomes cohorts. So this gives you the diagram to represent the study. So because we use the new user cohort, so we have the in here that we can see the day 0, that's the index day. We use the first DOAC prescription as the index day. So like all other study, we have to have a year of the observational period before that. And also we're looking into anticoagulant, the assessment window for the previous anticoagulant. So we use 180 days in here. So that will be the exclusion criteria if they have any other anticoagulant before that, because we want to use the new user cohort. And then we do the assessment of the atrial fibrillation. We have it basically looking into all the past history and also looking into the 90 days before that, because we know sometimes there's a delay in putting the diagnosis into the record. So we allow the 90 days afterward. And also we have to exclude the people that they have other causes of the arrhythmia. For example, we exclude people who have the mitral valve stenosis, and also people they have the mechanical heart valve put into it. So they are not the major use of the anticoagulant for AF. So we also have what we call the transient AF. So those are the exclusion criteria. So we exclude those people to ensure that we have a fair comparison, and also using specifically for the AF patient. And then we follow the patient up, looking into until they have the outcome measure that we're interested in it. So we follow the patient up and continuously until the 31st of December 2019. So we have we define the concept set. The concept set of the cohorts for the defining drugs exposure, outcomes, inclusion and exclusion criteria were divided using a combination of method. So we identify the code from the literature, and we use the keyword search in the avian. And also we're checking the related concept in the hierarchy of the identified concept to see if parents or child codes should be included instead. So we also have the cohort diagnostic, and those are in the GitHub, so everyone can actually access it, have a look. And also the other thing that we actually added 100 orphan concept into the concept set of the cohort after carefully review. So it gives us a very comprehensive of our set. We use the propensity score matching with the variable target to comparator to ratio was used to address the potential confounding factors between the DOAC groups. And for each patient, propensity score were estimated using the data-driven regular logistic regression model using the Synops package. So again, you can go to the GitHub to have a look. So based on range of baseline covariables, including drugs, conditions, procedure, and summary score. So those you can actually find all the detail. So we use the Cox proportional hazard regression model in terms of hazard ratio. We use the negative control for the p-value calibration, and the hazard ratio will pull across the database in the meta-analysis using the random effect model. So subgroup analysis was also conducted looking into specifically age over 80. That is highly important because there is very little evidence at the moment of using DOAC of patient about 80, because so far most of the evidence are actually based on a clinical trial. And also we did the sustained analysis looking into intention to treat and also propensity score stratification rather than matching. So again, you know, all the package are in the GitHub, so people feel free to have a look. So this is the result. We have the result in here. We have the apixaban, dabigatran, edoxaban, bifroxaban. So those are all the patients in different data sets in Germany, in France, in UK, and in US. Altogether, we have about 600,000 patients in it. So again, looking into all the characteristic, it's well balanced. The standard diet difference is less than 0.1 for all comparisons after the propensity score matching. So it's working pretty well. And indeed, that's what we expect to see, because we are not comparing the DOAC with warfarin, because in previous studies, we found that there's some challenging situation of comparing the DOAC with warfarin. But this time, because the direct comparison between the DOACs, so it's well balanced. So again, the patient characteristic, we see more or less the same thing. So it's no surprise, because again, we're comparing with DOAC's direct comparison. So they are the main analysis results. It's quite interesting. I must say that it's more or less that what I would think that most clinicians or most pharmacists, they work on this area. We have very little evidence to go for whether the digabatran is better than the rivaroxaban or edoxaban. So, but what we actually see in here is the green one is about the ischemic stroke and systemic embolism. It's very little different between the different comparison. And similarly, for the intracranial hemorrhage, it's very little difference of each drugs. It's quite similar. But the one that actually have the major difference is actually gastrointestinal bleeding. And that is actually the major side effect of any DOAC, or not just the DOAC, but also warfarin. And we know that any drug that can thinner your blood, reduce the blood clotting, will give you the potential bleeding. We can see that the apixaban is actually is actually standing out. Is better than all other drugs in here. So that's what we see in here. So in terms of the efficacy side of this, for the ischemic stroke and the systemic embolism, we don't find a huge difference. Neither we see the intracranial hemorrhage, but we see the gastro bleed is significantly different. Apixaban seems to be more superior than other drugs. So when we're looking into the age about 80, we saw the similar things. It's again, we see that the GI bleed is actually for the apixaban is more superior. And again, we don't see major difference about the efficacy side of it. So it looks like all the drugs are more or less effective as what we expected, even in the meta-analysis, they are pretty similar in terms of the efficacy. But having said that, the safety side of it do have a difference between them. So we're looking at the sensitivity analysis and looking into intention to treat. We don't see a major difference from our main analysis. So that gives us some reassurance that we're seeing something that we're probably seeing some differences specifically on the gastrointestinal bleed between them. And again, we use the propensity score stratification. We see very similar picture. We don't see any deviation from our main analysis. So in this particular direct comparison between the DOAC involving over 600,000 patients with the atrial fibrillation in 4 different countries, we found that apixaban is less likely to cause the GI bleed compared to other. But for other risks, they're very similar and they are very consistent even in patients over 80. So because there's no RCT, and also I do not expect to see a major number of RCT will occur in the future, because no company want to run a direct comparison with another new drugs comparator, because this is a really risky business. So the current study actually provides very important evidence to guide the clinician to use the drugs for the atrial fibrillation. But having said that, we think that we need to also have further study looking into the short-term indication, because this one that we're looking into is atrial fibrillation, but we know that the DOAC can also use the wing thromboembolism for short-term use. At the moment, again, we have no evidence which one is better or worse. The strength, we have a large population, and it's much better than all other study I run previously with one single database. This is actually the real strength of this study. And also we use the new cohort study. We eliminate a lot of residual effect of previous drug exposure. The limitation, again, I think is sort of like what we always say, that we can't actually say that this is a causal relationship of it, but certainly that what we see in here, it gives us some sort of indication which one is probably more likely to be better. There's always a confounded possibility. We cannot completely eliminate it. And we use the propensity score with the p-value calibrations. It gives us some reassurance that what we're doing is robust and valid. So the summary is I think in this particular study, the apixaban seems to be a safer option compared to all other drugs, at least in terms of the GI bleed, but there's no difference in terms of the efficacy. So what I would say that we would like the Asian group to join us. Unfortunately, the whole study actually is based on the European and also America. So I'm hoping that we will be able to actually mount another study using the Asian patients, because we know that the Asian, our response to the anticoagulant is actually slightly different. And also, we know that the number of the AF patients will significantly increase for the next decade. So it's highly important for us to also run the study in Asia to see that whether we will have the similar result or different result. So the final thing is, it's sort of like a hindsight of the whole thing. So, I run this particular study in 2018 in a multinational study, in a very simple study. It's a descriptive study, just looking into ADHD prescribing. It took me 3 years to run the study. It was a lot of things to overcome about the different data structure and different governance and a lot of different challenge to run a study, a very simple study, multinational study. But after I run this, CORAZON study in looking at the anticoagulant with the Odyssey team, I have actually found that maybe I should have done the study using the Odyssey a few years ago. It will save me a lot of hassle and will be much more easy to run it. It's much more beautiful, and so so I think in hindsight that is I am perfectly happy from now on to use the Odyssey to run multinational studies. So that's what I want to say. Thank you very much. Happy to answer some questions.
Awesome. Thank you, Ian, for that wonderful presentation. We do have quite a few questions out there right now for both of the studies that were just spoken about. So before we go to the questions that are related to your study, Ian, I want to round back to the hypertension study because we got a couple more questions that came in at the very tail end. And there are two of them, and I think they're very much tied to each other, or actually they're all tied to one of the ones that came in initially about how to consider initial drug treatments with either combination therapy in the study, and then also into in the number 3 inclusion criteria, patients started third class of drugs within 180 days of the index dates are excluded. How did you decide on the interval of the 180 days? Is that a sort of standard interval used within the hypertension observational study? Professor Lu, would you like to comment on this?
Yeah, sure. Yeah, sure. Thank you, Mui. I think it's a little bit arbitrary decision to use 180 days, and we make that decision based on a previous study Chen did on looking at combination therapy as the initial treatment, and that's what we do in the main analysis using 180 days. But we also do several sensitivity analysis looking at other intervals like 60 days, 90 days, 180 days. 120 days and 150 days, as for example, and then the result shows pretty much similar. And the number of people included in the cohort by different time interval doesn't change that much. So I think we would just decided to use 180 days as the main analysis and complement that result with several sensitivity analysis. And also, I think clinically it makes sense because we want people to be on this medication for a period of time, so then the drug medication have enough time to show their effect on the outcome. So that's our rationale. And I also see the other question saying that if people on drug A for less than 80 days and then switch to drug B, how does it consider as monotherapy with drug A or B? Actually, if they are in that case, then they would be excluded from our analysis. Oh no, actually they would be, if they switch to another monotherapy, then yeah, they would be excluded from our analysis because they didn't satisfy our inclusion criteria for the cohort. So in this study, we specifically focus on people who on the first drug monotherapy and then later on added to a second drug. So if they switch, then they at a particular time point, they only on a single monotherapy rather than on a combination therapy. That's why we will exclude it from the analysis.
Thank you, Professor Lu, for your explanation on those. Now we're going to go over to the next study, the study that Ian was talking about, the comparative effectiveness study. Now, Ian, we have a question on here, which I think you kind of already mentioned in the presentation that you provided, but how can one participate in the DOAC study if they want to in the Asia Pacific side? How does one get started to interact with the group that's working on this particular study?
Well, can you hear me?
Mm-hmm.
Yeah, that's great. Excellent. So we did put our community to call. So again, I think guys go to the website, and go to the community and check out what's actually available. So that is one way to do it. But of course, you can contact me directly. Then we will put you in touch with all the wonderful people in here. And indeed, Mui team has actually helped us to do a lot of work. So that is the way to do it. But as to date, almost all the speakers talk about, go to the Odyssey website, go to the community, you will find what you need.
Awesome. Thank you. Now, there's another question on here. It talks about, can you explain the orphan concept and how you found those orphan concepts?
Well, that is the question that I think Mui you probably answer better than I do, but my understanding is, because that is the technical side of it, and of course we have to go through, there are a lot of concepts in there, and a lot of mapping is already done, and also to give us what we need, but at the same time, there will be some orphan concept is not actually completely mapped into it. So we went through quite a lot of them and to identify what we believe those core are also appropriate for our own study. So Mui, would you like to supplement it?
I am the person that's really good at bouncing questions off of myself. Okay, I'm really good at doing that. So Jing, you're on the call. Can you guys talk about how you guys found it using the cohort diagnostic tool? Xiaoling, you're on mute.
Yeah, I was just like, muted myself. Yeah, so for the orphan concept that we actually use the cohort diagnostic tool, which is a tool that is developed by OC. So actually you can go to the GitHub website for and search for the cohort diagnostic tool, and there is a function in the cohort diagnostic tool that is orphan concept. So that function includes a concept which could be included in the concept set definition, and actually you can go back to the atlas and to add those concepts in the concept set definition.
Thank you, Xiaoling. We will post the link to the cohort diagnostic tool on the chat as well. Patrick or Chan, anyone of you guys want to give a little bit more information about the cohort diagnostic tool, or is that good enough for us? Chan's telling me we're good. Okay, I don't think we have any more questions that we have not answered. Last call for questions. Is there any other question that folks would like to ask this panelist that we have on the line here?
Meanwhile, I'd like to comment on the Ian study, because yeah, I'm really interested in that CORAZON study because I'm a cardiologist, and it was really interesting. And actually, the result was really consistent with the previous knowledge. The experts have some consensus on that apixaban is less bleeding, increase the dry bleeding risk less than other DOACs. So it was really, I think that this previous LEGEND hypertension study shows that thiazides can be the better option, optimal option for the hypertension, which is actually supported by previous RCTs and the American guidelines. And in this CORAZON study, we found that we generate the compatible result with the previous knowledges we have. So again, this is really interesting, and I hope that many Asian databases can join this study because, as Ian said, that Asian have some specific susceptibility to the bleeding risk, and their response to the DOACs is a little bit different from those from Western people. I actually tried to run that study on my database, but because my database is not so big, I cannot get the enough sample size. But after converting the nationwide claim data into AMOP-CDM, then I'd like to try it again. And again, please, folks in this call, please contact Ian and join that study. Thanks.
Yeah, definitely. One of the things that, because we work on a lot of GI bleed in Hong Kong, and we noticed particularly Chinese, we have a very high risk of GI bleed, even though not on the DOAC or aspirin. We have much higher risk than other people already. So we don't know how the whole thing pan out if we are looking into the Asian side of it. So again, if you do have the data, let's work together and then to generate another data set to the evidence to allow us to guide how to use the DOAC in Asia.
Yeah, I'd like to bet that Korean is more susceptible for the dry bleeding because we eat a lot of spicy food, and the gastric cancer incidence of the gastric cancer is highest in Korea and Japan. So you bet it.
I love how we've turned a presentation into a even better network study by involving another country. So this is awesome. This is great. This was not scripted in any way, shape, or form for those on the audience side. FYI, originally these two presentations weren't even linked together. So the two panelists never actually met each other before this call. So it's great to see how we can quickly get interest from different collaborators within the Odyssey community to work with each other. And this is really one, like Ian has mentioned, this is one of the beauties of the Odyssey community, being able to quickly collaborate with each other. I know we have actually, before we end, we have another question from one of our panelists. Nicole?
Yes, I'll take the prerogative and ask my question if that's okay, Ian. I'm really interested in knowing whether or not you're going to be looking at the dose or the strength that is prescribed. So I think, again, that's going to be a really fascinating thing we can do across different countries and look at the difference in outcome rates depending on the way that medicines are prescribed and what doses they're prescribed and who are they prescribed for. So is dose something that you'll be looking at?
Yeah, that is definitely is one of the things that we will look into. And also the other thing is we did some single site study already in the UK and also in Hong Kong, but it's a separate study looking into the GI bleed. We did notice the dose different significantly. There is sort of like, from our point of view, it looked like there is actually those differences also interacting with the race. We noticed that the low dose at least in Hong Kong, we use one of the DOAC is actually much lower risk to have the bleed. But in the Caucasian in England, we don't see the same difference. So we don't know whether some genetic difference or simply the environmental difference. Like Chan talked about that. Our diet is so different. It makes things different.
Awesome. Thank you, all the panelists, for that. Before we end this, we would love for you guys to listen in to our closing statement of the day. And don't forget, we still do have another session tomorrow. Patrick?
Thank you very much for attending the first day of the APAC Symposium. We hope that you've had a lot of interesting discussions as well as discoveries from all the different sessions that we've had today, ranging from the COVID-19 panel of experts, Kristen, Danny, Mark, as well as Chan, to the Legend Hypertension APAC study that was presented by Martijn, as well as Professor Lu. And of course, we can't forget about the comparative effectiveness study that Professor Wong presented at the end just a minute ago. Now, also, you guys might have attended the networking session. Maybe you've met a few friends along the way, but we're not going to stop there. Don't forget, we are only halfway through the symposium. We still have 4 hours of fun activities that's scheduled in for tomorrow. Just to remind everyone, tomorrow we're going to start off with the APAC State of the Community session, and then we're going to break down into the 6 regional chapters. Each chapter has a lot of different agendas and schedules and activities scheduled already, so don't miss out on them. You can go in and out of each one. You can hop into one, listen in. If you like it, stay. If you want to learn something else, you can go over to another one. Then at the end, we are going to ask that you guys join us for some fun and laugh during our Fun with the Community session before we close out this year's symposium. With that, I hope you guys have a good rest of your day and see everybody tomorrow. Bye.
Awesome. So good.
It's so good.